Welcome back to the CSP Elite Baseball Development Podcast. I'm your host, Eric Cressey, and this is episode 200. We've been on a podcast hiatus just to stockpile some content. This off season took a little bit longer than I expected, but I am fired up for this season's guests. Got some really good episodes lined up for the weeks and months ahead. And for a momentous number like 200, want to make sure we had a great guest to kick it off, and we have exactly that today. This is an orthopedic surgeon who is really at the forefront of not just managing baseball's injury epidemic, but also trying to come up with some good solutions to provide a better platform for baseball to continue forward and keep young arms healthy. So really learned a lot, not just on the call today, but even just chatting with him offline before we even hit record. There's probably not a guy in the business who has a better handle on just how extensive these problems are. He told me offline that really about 80 to 85% of his practice is baseball elbows, and the rest is shoulders and quarterbacks. So really, he is dealing almost exclusively with overhead athletes in his clinical practice day to day. So a guy who has an amazing perspective to talk through some of this stuff, and he shares some elite wisdom with us today. So enjoy. Overuse injuries have emerged as one of the biggest threats to players at every level of competition. As an example, at the pro level, ulnar collateral ligament injuries at the elbow alone sideline pitchers for roughly a year and a half. That's a ton of lost development and a threat to a lengthy career. Just as concerningly, though, for youth players, overuse is the predominant mechanism of injury that we see. So, what can be done? Obviously, we need to train athletes to prepare for all the stresses the game may throw at them. But at the other end of the spectrum, the other side of the equation, recovery, it really doesn't get the attention it should. Healthy, recovered arms mean you can stay in the game and give your best on the field. And that's where Mark Pro really comes in. Mark Pro is a cutting edge recovery tool that provides all the benefits of active recovery, but without the extra effort, muscular fatigue, or stress to tendons and joints that we get with a lot more aggressive active approaches. Players can use Mark Pro for as long as needed for exceptional recovery between training sessions or after games. We have 4 units in our facility, and I find myself constantly loaning them out to athletes when little issues or more than normal soreness surfaces. It's a great way to listen when it whispers instead of waiting for it to yell. I've handed these out to athletes before long flights so they can actually pop it on while they fall asleep on a flight and get some low-level recovery going while they're traveling cross country. It's both easy to use and portable. Mark Pro is a powerful tool that allows recovery anywhere, anytime. You can use it while you're relaxing at home, you're on the road, or during tournaments. On a personal note, I was originally a naysayer when it came to Mark Pro. However, longtime CSP athlete Corey Kluber actually turned me on to it. He adopted Mark Pro into his post-pitching recovery approach, and it was an integral part of him going out and throwing 200 innings year after year for quite some time. This led me to experiment with it myself and with more of our athletes, and the feedback was really consistently awesome. Now, just a few years later, you'll see it in pretty much every major league organization as parts of the routines of some of the most accomplished baseball players on the planet. And it's a trusted resource for some of the smartest sports medicine professionals that I know. So if you're looking for the same results enjoyed by these athletes, visit markpro.com/baseball. That's marcpro.com/baseball. And be sure to use coupon code Cressey, Cressey, at checkout for an exclusive discount. You won't regret it. Today's guest is a nationally renowned orthopedic surgeon specializing in the treatment of overhead athletes. He graduated from Boston University, completed an internship at Mount Sinai Hospital, and then moved to his orthopedic residency at the Boston University Medical Center. Thereafter, he completed a sports medicine fellowship in the Orthopedic and Fracture Clinic of Eugene, Oregon, a hand surgery fellowship at the University of Virginia, a sports medicine fellowship at the Alabama Sports Medicine Institute, and a knee fellowship at the Institute of Orthopedics Royal National Orthopedic Hospital in Middlesex, England. He served as an adjunct faculty at the University of Texas at Arlington since 2005 and also was a professor at the University of Florida from 1993 to 2004. He has served as the team physician for the Texas Rangers since 2004 and was also the Dallas Stars head team physician from 2005 to 2008. Previously, he served as the team physician for the University of Florida from 1993 to 2004 and to USA Hockey from 1993 to 1999. He has an extensive research background with many publications in academic journals over multiple decades. He serves as the director of the Texas Metroplex Institute for Sports Medicine and Orthopedic Surgery in Dallas. Please welcome to the show, Dr. Keith Meister. Dr. Meister, thank you so much for taking the time. I am extremely excited to chat with you tonight.
Eric, thank you. Thanks for the opportunity.
So for context, this is actually our 200th podcast. This is exciting.
Oh, nice. All right.
So this dates back to 2019. So we're coming up on 6 years with this. And what's I think most fascinating about this is not that I've actually stuck with it this long, but probably more significantly how the game has changed in just those years. I think we saw a pretty massive jump in injuries around, the COVID era, and they've
Yeah,
kind of stayed right there. I know you've been at the
right.
forefront in trying to help find solutions and just as importantly, ask a lot of the tough questions. But maybe the place to start is, with your experience both as an MLB team doctor and in private practice, you're in a really good position to comment on how injuries have progressed over the last few decades. Maybe shed some light on, from your perspective, how expansive this problem is and how has it changed over the course of your career in sports medicine?
Well, I actually, when I'm discussing the topic now, and even the stuff that we're publishing, we're going to get quite a few manuscripts out this year. I always say throw out all the data that's probably 2015, 2016, and prior. And in fact, probably throw out all the data and all the papers that are written 2020, 2021, and prior, because I don't think any of that stuff holds any relevance to today and the pictures that we're looking at today, particularly at the elite level, but even at the even at the younger levels. And so my own database, I don't even include the stuff that's kind of I call prior the years prior to the internal brace era, where we were not enhancing our repairs in some way, so to speak, because I think that I like to say in an arrogant way, I think we've solved the problem of the ligament. I think that we have created much greater problems, though, with the way baseball is taught and played today.
That's interesting. You've been maybe outspoken not just about the number of injuries you had, but even just more of the nuance, like the severity of it. Like,
Mm.
how is the average baseball injury presented, worse now than in the past?
I think that a lot of especially the re-injuries that we're seeing. So, as I said, I think we've done a better job at enhancing these reconstructions and repairs and whatever avenue we take to address the ligament. But but that's not what's failing, and that's what I've tried to kind of focus on. What we like to say, the pathomechanics or the pathophysiology of injury has changed significantly. Whereas we used to worry about these ligaments; they get worn out, or they may tear on the top end, or may tear on the bottom end, or blow out in the middle. Guys would say, "Yeah, doc, I can't get my arm into a layback position, or I actually have the injury in layback." That is a much less frequent storyline than what we get today. The majority, overwhelming majority of individuals that we see today come in and are complaining actually of their acute onset of pain at ball release, and then continued symptoms at ball release and just after ball release, which is a completely different injury. It doesn't mean it doesn't necessarily involve some of the ligament, but the primary problem in these individuals is the flexor. And
That's
and
interesting.
that's really what I've tried to get people to begin to understand, that this has changed.
Yeah, I mean, I think when we talk, you talk flexor, you talk ligament, they're specific. If we backtrack to general, and I think I asked this of Dr. Chris Ahmad back in the day when we was on an earlier podcast, but what in your view is it that makes an elbow so complex? Because we were talking offline, I think you said it's 80% of your clinical practice these days. Why is it that elbows are misdiagnosed so much? Why is it that, they become so troublesome, for many sports medicine professionals? For you, it's probably a very day-to-day occurrence.
I think the frequency of injury obviously is one problem. I mean, we know that the numbers, the pure numbers of injuries have gone up astronomically, and that lends itself to the way the game is played now. What's being asked of our pitchers, and it's the lost art of pitching. We like to say there is another better way to do things, but for whatever the reason, well, I know the reasons, but Major League Baseball is resisting and maybe going a little bit more old school, as we kind of were talking about earlier, and going back to the way guys used to pitch and talk about pitching. But that takes time. And there are a lot of organizations, most organizations don't want to take the time to develop these individuals. So what gets you there quickest? Stuff gets you there quickest, right? Velocity gets you there quickest. Ball movement gets you there quickest. And it's not just up, down in the vertical plane. The biggest problem I have is horizontal ball movement. To create horizontal ball movement, you have to begin to hold the ball completely differently than when guys were coming up in the, in years gone by. And I'll never forget, Dr. Andrews for years has his ASMI baseball meeting, and he would have Johnny Sain, Hall of Famer, longtime pitching coach, well respected in the game. This is back in the early 90s. I'll never forget a talk that he gave where he said, if you can't take a raw egg and hold it and throw it without breaking it, well, then you're squeezing the ball too hard. Well, forget it in today's game, because that's the way the ball is held today. In order to create movement on a baseball, you have got to squeeze the crap, pardon my French, out of the baseball. You have to put a death grip on the baseball, because if you're not doing that, you can't create spin, you can't create movement at the point of ball release. So what's happening pathophysiologically is that you've got maximum concentric contraction of your forearm flexors of the entire upper extremity, because it's hard to just squeeze a baseball and not fire everything else along that kinetic chain. I mean, you know that, right? I mean, the lat gets fired on, the subscap, the teres, everything is maximally contracted until the point of ball release. And then it's like a hamstring strain in a sprinter. All of a sudden you get this massive eccentric load on the medial elbow. So what's getting pulled there? Well, you're getting some valgus load. There's a second spike of valgus load that occurs at the time of ball release, which what we used to measure was not as great as what happens in layback. But I think that's inconsequential now, because what is getting pulled on, yanked on, is that flexor mass. And so you've got this previously reconstructed ligament, and now you just get this explosive type of injury occurrence. And as I keep pointing out to people, these injuries are not occurring from lateral to medial, meaning from deep to superficial, because that would mean the ligament is the primary problem. These injuries are occurring from superficial to deep, from medial to lateral. Well, what's most medial? The flexor is, because it's this eccentric overload of the medial elbow. And I mean, I can go on and on about the anatomy, and what happens here is you've got two primary raphes on the medial elbow in the flexor. You've got the raphe that's between your pronator and your FDS, flexor digitorum superficialis, and you have the raphe between the FCU and the FDS. And both of these raphes come together to come to this kind of common tendon point right at the apex of the medial elbow. And deep to that is what I like to term the proximal transitional zone, which is the zone where the most medial fibers of the ligament come in contact with the tendon. Well, you're yanking that common tendon, or either one of those two raphe, off. And what's it pulling with it? Well, it pulls the superficial fibers of the ligament off with it. And it's easy to see when you're looking at the pictures and you're looking at the anatomy and you're looking at an MRI scan. It's this aha moment. And you're like, oh my gosh, wow, that makes perfect sense. And so it's really, that's what's going on. It's an eccentric injury now to the medial elbow, which is dominating the problems that we see. And some of these look like, somebody stuck a stick of dynamite and just exploded these elbows. They happen so violently.
It's interesting that for so long we've talked about these high school kids, right, that have previous low-grade injuries, areas of calcification on the ligament. They become ticking time bombs. They get bigger, they get stronger, they turn 19, 20, start throwing 95, and then a ligament goes, and you go and you do a surgery and the ligament was bad all along. But it seems like you're almost hinting at the idea that previous flexor strains are kind of the whispers when, we're waiting for it to yell.
Yeah.
Would you look at it very, much in that way as well?
I think you're right. I'm again, this is a 180 from the way I used to look at these problems. I mean, I used to, earlier on, I used to see a little bit of edema in the flexor. I'm like, oh, that's always periligamentous edema. We used to terminate. It's the ligament has a low grade sprain, so you get a little bleeding into the flexor mass. And yeah, no, it's not really flexor. I've done a complete 180 on that. And I say, no, the flexor is your primary problem here now. And you have secondary ligament injury. But the primary issue is your flexor. And that kind of is the top two buttons on the shirt, I like to say. And then obviously the deeper you go, because these injury patterns are occurring predominantly from superficial, meaning more medial, to deep, to more lateral. And so and even your grafts, they're not failing. People are obsessed with their grafts failing at the mouth of their tunnel. How am I drilling too big a tunnel? How am I doing with my graft? This and that. They're focusing on the wrong thing. It's not that some of them don't fail like that, but that is not the overwhelming majority of them.
It's fascinating for me too, because I see some of the same guys that you see, and we also
Yeah,
have a really small, large contingent of just high school athletes. And what's
yeah,
fascinating to me is you had a 15-year-old kid that came in with medial elbow pain for the entire, first decade of my career. You're thinking growth plate right away at
yeah,
that age.
yeah,
And now the number of kids that are coming right in and they're pointing directly to their flexor tendon, like it's got barnacles growing on it. Like the
yeah,
tissue density is off the charts. I never thought that I would be referring, early teenage kids for manual therapy, things like that to help
yeah.
facilitate this. In the past, it was, hey, go play basketball. We'll come back to this, in a few months. But the tissue changes, they're very, very apparent. Do you think this relates also to, kind of just an ulnar neuritis being a consequence of it because of its interaction with the flexor tendon, obviously it being subject to some of the same forces?
Yeah, that's interesting that you bring that up. I was talking actually to my PA about that today. We have seen a big spike in ulnar nerve
Yeah.
symptomatology, and I think nerve problems. In I always say that TOS and these nerve issues that we're seeing now are these chameleon diagnoses.
Yeah.
They're everybody is saying, oh, it's got to be ligament or it's got to be flexor, and therefore, I call that the square peg in the round
Yeah.
hole approach. Well, these are our hammers that we have, so everything else has got to be a nail. It's like, no, I always say when it doesn't make sense, our job is to make sense of it, not
Mhm.
just go ahead and push through a diagnosis because that's the way we were taught or that's the way that it's always been, because that's not the way it always is now. And I think that neurogenic pain, I've seen a big spike in. And whether the predominant problem is up in the neck with
Yeah.
thoracic outlet or the predominant problem is peripheral, or equal contributions of both, it's sometimes hard to tell for sure. But yes, I absolutely have seen a big rise, a big spike in what I think are ulnar nerve problems.
Right on. Well, we've dug in on the elbow anatomy rabbit
Mm.
hole, so I want to keep that going.
Uh-oh.
I do have some questions, big pictures, but let's
Yeah.
talk about the hybrid approach, which you brought up before. You were one of the
Yeah.
initial pioneers of it. We had Dr. Jeff Dugas on previously, kind of talk about the origins of the internal brace. I'm
Mm.
curious what brought you to the idea of effectively combining a repair with a reconstruction, and maybe more importantly, beyond just the advantages, what are some key considerations that you relate to your patients after they've had this procedure and their therapists that are overseeing them during that rehab?
Yeah, well, look, a little bit of the history. Jeff was great and
Mhm.
instrumental in kind of, introducing the brace into circumstances of repair. I took a little different tact on this. I actually modified the technique that he liked to use early on, and instead of, putting anchors on both ends, I actually felt like it was difficult for me to properly adjust tension the way I wanted to adjust it by using a second anchor up in the medial epicondyle. So I used a docking approach. And this is from about 2015. I started this in 2014 using braces. And I felt like it was much easier for me to again nuance the tension within the brace, by docking it and tying a knot. And it also, then I said, okay, this worked well for a few years. And, these guys were doing well. And some high level guys, as I kind of kept pushing my own envelope on this, I got probably about 60 pro elbows, not including our revision repairs,
Mhm.
but 60 pro elbows with, internal brace repairs only,
Mhm.
and doing nicely. So, but obviously there's circumstances in which the tissue's terrible and you can't just put in a brace. So my first case was a kid by the name of Kyle Cody, out of the University of Kentucky. And in 2018, or 2017 actually, he had fractured one of those very, very large enthoscopic osteophytes on the medial side of the elbow. So almost the entire medial elbow was bone. And he had this painful fracture there, and it wasn't getting better. I couldn't get it to heal, fibrous union, bony union, whatever. So I said, look, Kyle, I said, we go in there, we're going to have a huge hole there. And I said, I've been thinking about this, doing this like this. He was in AAA at the time. I said, I think this will give you a better chance to come back, because you take out that big piece of bone, you're left with this big void. You're just hoping to fill it with basically a dead piece of tissue.
Yeah.
You're like, wow, how well is this going to work? So that's what we did. So we went ahead and we did. That was the first hybrid, and he did extremely well. And I'm like, wow, he got his motion back and stability, and he's still pitching today. Now he's 2018. He's
Mhm.
6, 7 years past his initial procedure. So I did a few more after that, and the ability to dock my internal brace made it easy for me to incorporate a tendon in much the same way. So I say basically what I did was I married the two procedures. I married a standard docking approach with a tendon graft with my docking approach with an internal brace,
Mhm.
and we set the tension with the brace, and then we tied the tendon down, and we got it down to the point we put the exact same number of sutures in every elbow. I mean, it is and try and reproduce everything exactly the same way, so that the only variabilities then hopefully become patient's own biology and look, nuances of therapy and everything else to try and figure out, hey, how do we continue to do this better? The other thing that I've always done very, very uniquely is I photograph every case I do. I'm actually a big underwater photographer, so I love taking pictures, and so it was a natural extension of that. And I take 15 to 20 pictures of every case. So every critical step we have a photograph of. And so when somebody doesn't do well, I can go back and say, damn, what did I do wrong? How can I do better? And so we've tried to, evolve in a very technical, very, very compulsive, I guess, kind of way. Um, and they have, look, they've done extremely well. We've got now close to 500, hybrid reconstructions, and two-thirds of those are actually pro elbows. So it's an elite level group of individuals. We're writing those all up now, and we wanted to make sure. I wanted to make sure. Look, I had a substantial number that
Yeah.
were at least 2 years out before I got on a podium and said, "Hey, this is actually maybe potentially moving the needle in the right direction." And part of the impetus for all this, and part of my kind of confidence that we were heading in the right direction was that I started doing all my revisions like this, and now I've got 86 hybrid revision reconstructions, and over 80% of those are pro elbows. And knock on wood, we actually haven't had a graft failure.
That's
Now,
incredible.
yeah,
Yeah.
now
On
that's not to
revisions.
say they're not going to
Yeah.
fail. I mean,
Yeah.
I'm not going to sit here and tell you that with any kind of arrogance that I
Yeah.
don't have failures and that these aren't going to fail. But the point is, at least the tissue's healing and the elbow
Yeah.
stable. Um, we've only had one graft failure that I know of, at least. And again, most of the guys are going to come back to me, or I'm going to hear about them, and we're in the process
Mhm.
of doing a better job, I think, of following them up now. But I had one major league pitcher about 4.5 years out, and he signed a free agent contract with the club, and we had a normal looking graft, normal looking ligament. Well, he started throwing a sweeper um, in this with this new team, and never had thrown it before. Was now throwing it 60% of the time. And by the middle of the season, you ask about the appearance of these failures, the entire elbow exploded. I mean, the flexor mass ripped off completely, the graft ripped off completely, and it started with the flexor and then into the ligament. And so, he's now a revision hybrid
Yeah.
reconstruction, and knock on wood, so far so good. But these are kind of the way things have journeyed for me in moving forward with this. And now every reconstruction, so meaning if the tissue needs a tendon, I do a hybrid. Now, on the rehab side, what we have found, and I make this very clear, and this is one of the things we've had to teach the therapist, is that it does take longer to get elbow flexion back.
100%.
So it is a little bit more of a constrained elbow. And so there are some nuances, as you guys have noticed and noted, and your PT Eric
Yeah.
is phenomenal about communicating these things to not just me, but back to the players, is that they just don't worry, your flexion will come. Don't push it though.
Yeah.
Otherwise, you get a hot elbow, and then you get a real mess. And so there is some burden on the therapist, to kind of just be cognizant of that aspect of it. And then I do think it does constrain the elbow more, and it tends to take 10, 12 months for that elbow to get that whippiness back.
Yeah.
Where the joint reactive forces kind of release a little bit, and that compliance that's necessary is there again for them. So I would say that may be a difference that we see more routinely with the hybrids.
Deflection is a big, big thing. I mean, I'm losing track of how many guys who have maybe wound up with us in one way or another, a little bit
Yeah.
flared up. And the
Yeah,
first thing you do is you stop pushing flexion. I think in many cases
that's it.
we've hopped on a call with you
Yeah,
and maybe it's a week of anti-inflammatories, and before you
that's
know
it.
it,
Yeah,
their motion's great. And it's a week or two and they're good to go. One of these
right.
actually I was thinking about as you kind of described it, early on in my career, there were a lot of Tommy Johns that were starting their throwing program at 4 months. And
Yeah,
we both know it was throwing darts, it was babying it. They were very, very tender
yeah.
early on. I know you've been a proponent of waiting longer, and it's been an absolute difference maker just in terms of what we can do to get some of their force plate characteristics back, to train some rotational med ball stuff, just to find that extra month or two to be athletic before they start throwing. What's your official position statement on where you like guys to start throwing after maybe an initial hybrid reconstruction, and how has that maybe changed over the years?
Yeah, I probably got a little more conservative. I trained with Dr. Andrews back in the early 90s, and we tended to be very aggressive with throwing programs. But I think he also saw that. The more aggressive he got, the more failures he had.
Yeah,
So, and then we're dealing with a different athlete now,
yeah,
right? The stresses and the loads that these guys are putting on the elbows is much greater, number one. Number two, throwing gets boring after a while, right? If you're not throwing in toward a goal and just going up there and throwing darts. I mean, I'm not sure. I'd rather you have them working on their athleticism, right, and working on their balance and working on their total mobility
mhm,
and their fluency. And then when they're ready to throw, the throwing comes easier. Number one, and number two, it's less stressful. Number three, it's more patterning of what we need to see from them. It's
yeah,
actually their arm slot and their throwing. And so for me, I mean, you asked the question for my elite level guys, and that's maybe upper level college and pros. I start them throwing it at 6 months.
mhm,
Now we start their plows at 4 though.
yeah,
So they're doing 2 months of
wow,
plows and they're loading their elbow
yeah,
in a very controlled way that hopefully is adding to their athleticism and whatnot, and as part of the process. Now they're college and high school kids, and a lot of that is because the seasons just kind of unfortunately dictate some of these things to us. I start them at 5 months.
okay,
But again, I look at the calendar and I say nothing's cookbook. I always like to say, what's your finish line, right?
mhm,
Let's work backwards from your finish line.
yeah,
Because if we have 13 or 14 months, we don't need them,
yeah,
throwing in a game in the middle of December.
sure,
So I think just be sensible, be practical. But as
okay,
general guidelines, 6 months for, the more elite level guys, potentially 5 months for the high school college kids. Let's face it, they're generally going to have to put less stress on the elbow
yeah,
when they're facing a lineup, right? They're not going to
yeah,
be facing a bunch of hitters that can hit their stuff if they're fairly elite level guys.
yeah.
But I think that reflects again just some of the population that we're taking care of also. So I can play that game some.
That's a good differentiation. I think that's important. You're
Yeah,
right. It's harder throwers, more arm speed, more stress. As a friendly reminder, this episode is brought to you by Mark Pro. It's a cutting-edge recovery tool that provides all the benefits of active recovery, but without the extra effort, muscular fatigue, or stress to the joints. This is something that's a huge hit with our athletes at Cressey Sports Performance, and I use it absolutely every day. If you're looking for the same results that these athletes get, visit markpro.com/baseball and use coupon code Cressey at checkout for an exclusive discount. Um,
yeah,
we've talked a little about flexor repairs, and obviously you've spoken to how the injury has changed. It's a very, very different presentation, maybe the origin of all
right.
these problems. I'm sure we're also diagnosing it much, much better. But when you talk about the actual surgery, what are the unique challenges of the surgery? And we're managing one of yours right now who had both a reconstruction and a flexor repair at the same time.
Mm.
Where do you run into trouble with those things? And then also from a rehabilitation standpoint, any key tidbits that you think are important?
Yeah, look, I mean, I think first off, we're repairing a lot more flexors with ligament
Yeah.
reconstructions. I think because it's a real injury there. And I think that's one of the things we need to recognize on the MRI scans when you're looking at these injuries. And I kick myself because there are a couple that I've, subtle ones that I've missed. So I've gotten much more aggressive
Mhm.
in kind of what I call a two-layer repair. I repair and reconstruct the ligament, but I also very often will add an anchor to the flexor tendon footprint, even if it's a very subtle injury, because I think that those things can turn into a big problem with the way guys are throwing now. So,
Mhm.
I mean, for instance, just our pure numbers, I've got 85 or 86 combined UCL flexor tendon repairs now. Yeah, and that's on the primaries. That's
Yeah.
not the and there's only one real study in the literature, and it's like 6 or 8 patients.
Yeah.
So, as I said, I think that speaks to the differences
Mhm.
that we're seeing now
Yeah.
in this injury. And I think that as surgeons and clinicians, we need to recognize that there's more damage than just the damage to the ligament. So, what
Mhm.
I tell guys is don't hesitate to put an anchor up
Yeah.
toward the flexor tendon and just reinforce that, that area of potential breakdown.
Just for
Kind of.
context, how many flexor interventions like this, whether it's the full blown repair or just like a subtle stitch, like you mentioned, did you do before 2015? Because obviously the
Oh, God,
numbers have surged,
almost
but
almost never.
I had never seen it in the
Yeah,
first 10,
yeah,
15 years of my career. And
yeah,
now I feel like it's every other
yeah.
week we get one.
Yeah, and well, Dave Olchek
Yeah.
has the only paper out with a clinical group of individuals, and
Yeah.
a approached the problem very differently,
Mhm.
and B the series is extremely small, and I mean, heck, we'll do that in 2 months now.
It's incredible.
What he published, yeah, I mean, it's just it's like I said, it's a very different injury pattern and
Mhm.
mechanism, and that to me is the most important thing. If we recognize what's going on and why, then hopefully we can do a better job of fixing these things.
Mhm.
How long they last? Well, that's a whole other
Yeah.
level of discussion. I mean, it's because that's changed immensely as well.
I feel like the conversation I've had with the isolated flex repairs that we've had is a
Yeah.
lot of them feel incredible at 9 months. They feel like
Hmm.
they're ready to get in that 3 month
Yes.
period between 9 and 12. They all feel like they're ready to go back. And having looked at a lot of these guys from afar, it seems like that's where the setback happens. And it's just,
Yep.
you don't get that with UCL reconstructions because you're waiting for the graft to kind of take
Perfect.
on the ligament
That's a
properties.
great, yeah, and honestly, that's a great point. And actually, because in more recent times, I used to tell guys, "Oh, you'll be back in 9 months after a flexor tendon repair." But again, the velocities,
Yeah.
the spin rates, all those things that have lent themselves to the problems that we see on the flexor mass have also increased load on that repair, and so that, yeah, we if we try and push them too quick now, I tell them all a year. I
Mhm.
mean,
Yeah.
maybe they get better before then a position player for sure,
Yeah.
but not yeah, not a pitcher. I tell them all a year, and I just feel like anybody that tells them sooner than that just maybe just hasn't seen enough of them at this point. More recently, I
Yeah.
should say, and they're being overly optimistic.
Maybe switching gears a little bit. Your crew at TMI has been one institution that's really at the forefront of using biologics, to aid in conservative management. I think we've talked a lot about surgeries tonight, but you also,
Mm,
have a keen eye for understanding what's going to do well non-surgically. There's some times when I think, the world of biologics, are maybe the wild, wild west, and other times when, we've seen really remarkable results with things like stem cell, PRP. Do you have any big picture thoughts on, the use of biologics, where it's been, where it's headed, how you guys view it, at your clinic?
yeah, look, I'm not perhaps as big a proponent as you might think.
Mhm.
I think we're very careful in how we use them
Mhm.
because the truth is the science and the data doesn't support it.
Mhm.
Um, we use I probably use it more than anything, not as a healing enhancer, but as an anti-inflammatory. And
Interesting.
so the reality is, if you look at the bench studies on stem cell, there's just not a lot of good support for its use for soft tissue healing. Now, some of the animal models in looking at arthritic changes, yeah, there may be some value, and even why we don't know. That's the problem. We don't know. But to think that you're going to inject these quote unquote stem cells, and there's really a lot of question as to whether or not those are truly what we call pluripotential cells and are going to differentiate automatically, snap of the fingers into their surrounding tissue. Well, that's not the reality. So, what what we've been using a lot of are the amniotic growth factor derivatives, and the reason being is their concentration of what we call IL-1RA, interleukin-1 receptor antagonist, is a potent anti-inflammatory. And that all comes from the work in Munich on the regenikine and orthokine and
Yeah.
whatnot. So it's got a much higher concentration of IL-1RA than standard PRP does, at least from some of the labs that we look at and ask for this information. So I use it as an anti-inflammatory. Now, is it doing anything else? I am very candid with players, and I tell them I have no idea.
Mhm.
I said maybe, But I said, I'm not going to sit here and tell you that that's why we do it. And a lot of guys will come in. They say, look, you did it to me last off season. I felt great.
Mhm.
And so I want it done again.
Yeah.
I say, fine, but I don't, that is not a big part of my practice per
Mhm.
se. And I sell it really more as an anti-inflammatory that we
Mhm.
use as recovery in the off season.
Interesting.
During the season, again, I mean, I'm looking more obviously at steroid
Mhm.
injections, and we limit those. And again,
Yeah.
if the steroid only work for so long and they want something else, again, I don't like to keep putting steroid in a joint or around a
Yeah.
rotator cuff or whatnot, and we'll take the biologic route. But from that standpoint, for me, it's maybe a more effective anti-inflammatory and
Mhm.
and more biologically safe with respect to a corticosteroid injection or whatnot. So that's kind of my general stance on it. And again, we do get a lineup of guys after the season, but that is always the speech I give.
That- That's I think it's a breath of fresh air. I think people tend to
Yeah,
be very, very, the pendulum swings too far in one way or the other. They're either completely against it, and some people are just throw it into everything and without
yeah,
necessarily having necessarily a whole lot of context. What about visco supplementation, like hyaluronic acid injections? I feel like we're seeing a lot more of those in kind of these. I mean, we're probably going to see a lot more with all
yeah,
these 16-year-old Tommy Johns, but it does seem like that has kind of caught a little bit more momentum. And I feel like I've spoken with a number of veteran pitchers who have responded really well as they just lay down more
yeah.
bone and that joint space gets more limited. Are you seeing more of that?
Yeah, we do. We use it. Again, that's something useful in the middle of the season or in the off season. Again, depending upon the individual, with or without steroid,
Mhm.
with or without PRP type or
Mhm.
growth or amniotic injections. Again, it
Mhm.
depends upon diagnosis and what your goals are and where we are in a particular time of the year and season.
That's
But
great.
I agree with you. I think guys, I I think perhaps guys are throwing longer with
Mhm.
a lot more pathology.
Yeah.
And it may be well because they're able to, to offset some of the stuff because their fitness level is just
Mhm.
phenomenal. Their muscle envelopes are that much better and everything else. But I think they're more symptomatic also because again they're putting more stress. They're still throwing the ball hard. They're still spinning the ball a lot at advanced ages. So I think that we used to see really bad elbows and guys would be like, "Yeah, no, I'm good. I just my normal soreness."
Yeah.
And now it's, yeah, well, I need what can we put in there,
Yeah.
to make it feel better. So
I think that makes, I mean, guys
yeah,
recognize that with the pathology that's in place, careers get a lot shorter. So I think they're looking for any
yeah,
way to prolong what they've got. Maybe
yeah,
in the context of looking ahead, what do you think the next frontier in baseball sports medicine is? I think it's been challenging over the last 5 to 10 years as, let's be real, we didn't see a lot of the injuries. I mean, I saw an anterior shoulder dislocation in a kid throwing a weighted ball last year. I mean, and,
yeah.
dental
I mean,
injury is
that's
it's
yeah,
a football tackle, and we're seeing it now throwing a baseball. Where do we
yeah.
need to improve the most? Like, is there anything that really excites you as you stare off into blackness at 3 a.m. and think about what you wish you could fix?
Yeah, I think I'm staring off into blackness too many nights at 3 a.m. Unfortunately, that's my MO. It's an obsession for sure. I just look. I think overall, I think the challenges are not going to change at the bottom until they change at the top. And I am not afraid to say that if Major League Baseball does not begin to change what they are asking for in our athletes at the older levels, well, they're certainly not going to change at the lower levels because you have all these facilities that are catering to these individuals that want to go out and impress scouts. Well, what are the scouts doing? They're coming out with their radar guns and their TrackMan data, and this is what most teams anyway are applying and using to rate and grade the individuals that they're going to draft. So, what are these young kids going to do? They're going to go to the facilities that are going to teach them how to do this. And I don't blame the kids and I don't blame the facilities, but at the end of the day, what unfortunately we're not seeing from these places that are teaching these designer pitches and whatnot, we see the wonderful results they have in the moment, but you don't show them 3 months later walking into your facility or walking into my office because they're broken, and that's the problem, and that's what doesn't get publicized enough. And again, I think these guys, and you included, have done a great job of kind of figuring out better ways to make the body move and move more efficiently, and as a consequence, throw the ball harder and make the ball move better. But there has to be some level of responsibility and understanding what the consequences of this are, so that you don't give an AR-15 to a 12-year-old. I like
Yeah.
to say. I mean, it's irresponsible. There is a certain amount of learning and education and maturation that the body needs to go through, and then you don't drive your car all the time by redlining it, right? You don't put your pedal to the metal every time you walk into your automobile and sit behind the wheel of a car. How long is your car going to last? It's just not going to last very long. So, I mean, this is not rocket science. And so, where would I like to see things going? I think that a shift back more to an understanding of there is another way to do this in a better way, in a healthier way, which is going to be healthier for the game and healthier for those that play the game. Now, I think that again, what we spent a lot of time talking about is this whole issue of the flexor mass and understanding what's going on with the flexor. I think this is something people really need to grasp hold of and understand, because what this is going to change, hopefully, is a little bit of our approach to how we're rehabbing our reconstructions and prehabbing those individuals getting into the season. I think we need to do a lot more work in understanding, and this, I'm going to throw this at you, in figuring out how to better train eccentrically these muscles that are so important in the throwing motion. And that is a very, very difficult thing to do.
Yeah.
I had a long conversation with one of the medical coordinators for one of the major league teams during the winter meetings, and he said, "Well, you can strengthen isometrically at different angles, and that's going to hit your eccentrics." Well, I beg to differ with that. I actually spent my first 11 years in academics at the University of Florida, and there's a guy there that has spent his entire life looking at the effect of negative work on muscle eccentric strength. His name's Mike McMillan. I don't know if you've heard of him or talked to him. It'd be an interesting conversation to have with him. But he's come up with this basically this box, this device that he hooks up to most equipment and most machines, and it adds a heavy negative rep to your concentric rep on your machines. And so, I mean, it's a very direct way of training eccentrics. And I think that that's a part of what we're not doing well, and we don't understand well. That is really much more in your purvey than mine. But I understand that is critical, man. If you can figure this crap out, and we can begin to load eccentrically, these upper extremities in particular in a measurable way. That's the key, right? How do you do it in a measurable way? Measure the load that we're putting on and measure the gains that we're making. And I think, to me, that is an area that is going to be critically important in maybe effectively mitigating some of the problems that we're seeing now.
Yeah. The analogy I use with respect to the flexor is it's actually very similar to what we've seen with adductor strains in hockey players,
Okay.
where adductor weakness is tremendously predictive of groin strains in hockey players. But at the other end of the spectrum, every time a hockey player has a sports hernia, they walk in with crazy dense, nasty, fibrotic adductor longuses where it attaches on the adductor aponeurosis. So you're asking a tissue that's incredibly important. It has to be long, and it also has to be strong. It has to have extensibility, so it's not likely to tear there, but it also have to have plenty of eccentric strength over an extended kind of range of motion in order to perform, at all these different demand points. So it is, like you said, it's a challenging dynamic from a pure
Right.
disposition and the speeds involved. But I think you hinted at it maybe earlier, is just that more and more of these injuries are happening. They're happening at ball release. They're happening at elbow extension, where we all thought we just had to
Yeah.
protect against layback, but it's a very different injury mechanism now.
Completely. Yeah, I think people need to recognize that. I think for me, it's an old school way of thinking. And it's not that some injuries don't occur like that, but that's not the predominant ones now. That just isn't. I mean, it's just not what we're seeing when these guys walk in and complain. It's not that doc, my arm hurts from layback. My elbow, I should say. The shoulder, that's a different issue. But
Yeah.
but absolutely.
I think if you understand that injury mechanism, it also
Mhm.
allows you to appreciate why we're seeing more lats, why we're seeing more teres.
Absolutely. Absolutely.
We're seeing
Same thing.
musculocutaneous nerve injuries. We're seeing a lot
Oh
of
my
stuff
gosh.
that take place in that vulnerable position of ball release. That's a good one.
Yes. Yeah.
Maybe it's a good follow-up. MLB just released a report that featured the
Hmm.
results of interviews with over 200 opinion leaders around the game. I was interviewed. I know you were too. I think they were all done in, February, March of 2024. I thought the report did a good job of, maybe highlighting just how multifactorial the problem was, but it did stop short of making very specific, actionable recommendations on how to improve these things, right? And you've hinted at some and said some really definitively on this call. I'm curious if you had your magic wand and maybe you could even play commissioner for a day, where would you start to start chipping away at this, both at the professional and the amateur levels?
Well, I've taken this all the way up to the commissioner's office because I actually look, I think first and foremost, you can say it's multifactorial, but at the end of the day, the direct correlation with injury has gone on with increase in ball velocity and increased spin rates. That's it. So until the game recognizes or admits to itself, because we all know it's there was nothing in that report for those of us that deal with this every day that was new, right? I mean, we all know the report, I think, was nice for the media. I think it was nice for the average individual that has an interest in baseball to understand what we've been seeing now for a bunch of years. So, but it comes down to ball velocity and spin rates. And until you are somehow figuring out how to better control that and the use of those things in the game and asking for things differently, well, it's not going to change. It's just not. So I think that's my big issue. Now, how do you change the game? Well, I've had some interesting discussions with people, and I can't say that all of this is my own, thought process. But let's face it, you've got the NFL and you have the NBA that is willing to make some drastic changes in the way they play the game for the betterment of player safety or watchability. Right? I mean, we want eyeballs, we want players, and or certainly we want people growing up watching interested in the game, and that's going to continue hopefully to foster a great group of athletes that will want to continue to do such. So what I suggested first and foremost was eliminating on a two strike count, eliminating a foul ball on a two strike count, meaning that if you foul a ball off on a two strike count, you're out. All right. So now what does that do? Well, that's it. We've looked at that. And actually it reduces the total number of pitches thrown in a season by 8%. And if you think about what those pitches are, those are all high leverage pitches, right?
Yeah.
Those are balls thrown with a two strike count. And if you understand the history of the game, and this actually Neil Elitrash brought this to my attention when I brought this up to him, and we discussed it. And he's like, "Wow, that's a great idea." I said, "Well, yeah, sell it to MLB," because he said, "You know why that bunting a ball off with a two strike count is an out, but not a full swing." Well, back in the days of Christy Mathewson and Walter Johnson and those guys, a foul ball was just a dead ball. It didn't even count as a strike.
Wow.
So these guys went and complained to the commissioner and said, "Gosh, you guys, we only have so many bullets in the gun here. These guys are just going up there, squaring up the bunt, and pushing the ball off to the side." Sounds familiar, doesn't it? 100 years later.
Yeah.
But now guys have such, ability with bat control. They can just
Yeah.
go ahead and, Adrian Beltre, I used to watch for years, just do that. He was a master at it and prolong the at bats and wear down a pitcher. So that's why squaring out off for a bunt and fouling a bunt off became an out. Well, I
Awesome.
propose, hey, look, in fast pitch softball, you foul a ball off on a two strike count, you're out.
Mhm.
So I went up and calculated the numbers. We reduced the number of pitches by 8%. Well, they came back to me and they said, well, that's going to increase the strikeout rate from 22 to 30%.
Yeah.
And I said, well, that's really a specious argument because that's assuming that hitters don't make any
Don't
adjustment at
adjust.
all,
Yeah.
right? So what's going to happen now? A hitter's going to have to get more aggressive earlier in the count. So hopefully now we're going to see more bat to balls in play, which is going to be great for the fan, right? It's also it's potentially going to speed up the game immensely,
Mhm.
right? And by
Yeah, it's
by
true.
eliminating these long at bats and
These 14
whatnot,
pitch at bats.
and it's going to save maybe a pitcher's arm and elbow
Yeah.
if if again their workload is reduced.
Mhm.
So and I said I kind of pleaded with him. I said try it in the indie league, right?
Mhm.
Try it in indie ball for half a season, which may not be enough to really tell,
Mhm.
but try it somewhere where there's some reasonable chance to understand the implications of this, because no hitter's just going to go up there and
Yeah.
just give up an at bat like that. He's going to have to make an adjustment, and so I actually, Max Scherzer and I talked about this at length, and Max doesn't rarely agrees with anybody else's ideas, but this was interesting. First
Max
time
isn't
I
opinionated at all, is he?
Oh yeah, I love Max. He's one of the smartest guys, man. He really is very bright. But and I say that just kiddingly. But he, I told him, I presented this to him initially, and he was like, "Oh, man." Then he came back to me. He said, "That's not a bad idea."
Mhm.
And so, some hitters said, "Well, maybe that gives too much advantage to the pitcher." So I said, "You know what? Then 3 balls is a walk."
Mhm.
Right? So now it forces a pitcher to throw strikes. It
Mhm.
puts strike throwing at a premium,
Mhm.
and it throws, puts fielding as a premium, and again, it changes the dynamics of the game
Yeah.
to make it more palatable for the fan, and maybe again reduce the workloads on these arms
Mhm.
that we're seeing, and maybe workloads, all the oblique strains that we're seeing in hitters.
Yeah.
Maybe now they're changing their swings a little bit, and
Mhm.
not everything has to have a trajectory of X number of degrees because they
Yeah.
have to hit it out of the park.
Yeah.
I mean, we're just going to hit a line drive again, right?
Yeah.
That
I
would be
mean, I
nice to
always say
see.
everything with hitters is
Mm,
downstream from the pitchers, right? You
that's it.
see really good pitchers, you're going to see
There you
way more
go.
hitters trying to take live ABs and pitch simulators, and they're getting 2,000 plate appearances a year before you know it. More risks,
There you
more
go.
obliques,
So
everything
I
trickles
just,
down.
I just think there needs to be some flexibility and thought
Yeah.
in the game. And if you look at the Savannah Banana Club,
Mhm.
right? I mean, they're expanding 2 more franchises. They
Mhm.
go to these major league parks and sell out. You can't get a ticket, but they've made the game, obviously very entertaining
Yeah.
for the individuals. And I think that, again, that's we don't need Harlem Globetrotters, so to
Mhm.
speak, on a major league baseball diamond
Mhm.
in a game. But I think there are things that we have to be, I think, a little bit more flexible about that maybe will have positive health implications as well.
Absolutely. That's
As
good. What about the younger levels? Do you think it's a trickle down effect from the big leagues? Like if they clean it up on
Absolutely,
that side, what they scout?
absolutely.
Yeah.
Yeah, if you ask for something different, you're going to get something different, right? Then everybody else is
Mhm.
going to have to change their approach, their philosophy
Yeah, it takes some time to
with
do.
respect to how we're going to develop. I mean, the athleticism is still important,
Yeah.
but pedal to the metal, redlining every throw
Yeah.
is we gotta we
So
gotta change that.
race to the
We have to
bottom.
change that. Yeah, no,
Yeah.
yeah, it is
Well, this was
exactly right.
awesome. You have a wealth of knowledge to share. I
No,
appreciate you carving
no,
out some time. I know you had a
hey
long
man.
day in surgery and doing a million different things. So I can't thank you enough for taking some time. This was
No,
awesome.
thanks, Eric, for having me. I appreciate you.
My
Yeah,
pleasure. And,
this
and
is
folks
this is
can learn more
great.
about you. It's tmisportsmed.com, correct?
Yeah, that's
All
us.
right.
Yep, that is us. Thank you.
Terrific. Thank you again.